Yeah, thank you, Professor Arun Jain. First of all, really nice you have included me in this interesting instruction course. Already we had terrific presentations on this beautiful tool for surgeons who are looking for beyond the vision. I think the quality of vision, which is so important now when we talk about the refractive cataract surgery. I think it's not only the surgeon's hand, it is various tools which has given us the concept or reaching up to the quality which is required for a refractive surgery in cataract patient also. This is a review article published in IGO by us. People can go through this, which is very comprehensive on toric IOLs. We all know in our practice, toric IOLs will constitute around 30 to 40% of our cases where you may have corneal toricity of more than one diopter. And now it has also increased the load if you're looking for a multifocal, trifocal lenses. There, even a zero point 0.5 cylinder of in the cornea may not be giving a good results. Therefore, you have to look for a toric trifocal or multifocal lenses there also. Interestingly and fortunately, post-op surprises after toric IOL implantation are not that common, and therefore the results have been quite encouraging, and many people know that toric IOLs are the lens for correcting corneal astigmatism for all patients undergoing cataract surgery. This is nicely explained by Chintan that topographer as well as the wavefront analysis gives you a advantage in toric IOLs in terms of pre-op planning of a lens, as Dr. Arun talked about, intraoperative assessment of your alignment category by Jaldivar caliper, and most importantly, the toric assessment after surgery is the most important application of this eye tracy tool. This is what we look for: corneal curvature power, which is given by the topographer, which iTrace has, and the angle alpha, and the internal and the corneal aberrations separately by this iTrace gives you the analysis for a toric calculation of IL power, axis, and also takes into consideration of your surgical induced astigmatism. You can plan according to your incision, which is maybe superior, inferior, or any other area. Entire calculation can be given by this. This wavefront analysis, Chang analysis are talked about. This is a patient where you can see patient has, if you look at internal aberration wise, patient has a high cylinder. But if you look into the refraction cylinder is concerned is almost nil. But if you see the cornea doesn't have cylinder, cornea has cylinder of around 3 diopter cylinder in cornea, but refraction cylinder is not there. So this is the patient who had come for a presbyopic lens exchange. We understand the patient would be compensating the corneal cylinder by lens. So this is a patient, if you do a cataract surgery, toric lens is indicated in such patient to take care of a corneal cylinder. Angle alpha was greatly discussed. Larger angle alpha will definitely be a problem for all type of lenses, except for a spherical lens that has to be taken into consideration. Other important thing as separating the total aberration from the corneal aberrations. If you see here, this patient doesn't have a significant corneal aberration. So this is a good case for a toric or a multifocal, which Dr. Rajesh is going to cover. The cornea is healthy, no aberrations. The outcome going to be much better in terms of quality of vision. You look into a point spread function or MTF values will be very good in this patient. So this is a different patient where you can see the cornea is totally aberrated, multiple red and yellow, blue bars, significant RMS values are there. So this patient would require a procedure which takes care of our corneal aberrations. So inbuilt Toric calculator, which is there in iTrace, though many people may not be using this in today's generation of various IOL formulas and optical biometry available, because this device doesn't give you axial length. There's a major flaw in this. Otherwise, this gives you all the other parameters. So still, can give you a good Toric calculator based on the entire parameter which you can feed here. You can have a current center corneal power, best fit spare for a conicoid, spherical aberrations, inferior superior axis power difference, all are available here. Apart from that, then you can look into a pre-op astigmatism, internal optical aberrations, entire eye astigmatism, incision size, location, everything gives you a calculation of IOL power and axis of implantation also. And you can modify as per the desired radial cylinder and axis. We all know we would desire to have a little bit of, with the elastic mechanism minus cylinder 90° for post-op patients, especially for if you use a monofocal lenses to give a little more uh, uh, perception in terms of improving the near vision for these patients. Gel level caliper also helps in giving you a guide. If you have put mark physically by pen, either bubble marker or a slit marker, you can take the patient to eye trace, and that will give you a new assessment based on your mark to exactly give you a new axis of toric implantation. So this is the reference mark by bubble marker, and this is the IOL axis now required to be placed. And gel level caliper gives you the distance from your initial mark to a new IOL placement mark. So this is a very important tool which can be helpful if you don't have image guided surgery at your hand. Same thing is explained here. You can enter your pre-op cylinder, axis, incision location, and your SIA, and gives you a new area of concern. And it can also tell you if you shift your incision, what is going to happen. So if you have a 180° incision, so this is your area of placement for eyewear. But if you shift your incision superiorly, the IOL placement changes a little bit as per the new calculation by the Toric calculator. And I think pre-op wise, it gives you all the aberration profile, suitability for a toric IOLs. And if you can use Toric calculator, it gives you a power as well as for axis implantation, and also help you in getting a new axis as per your physical mark onto the limbus in these cases. But classically, what we have been doing for last more than a decade now is use this for a post-op assessment or toric IOLs. All patients, premium cases, do undergo eye trace examination as well as pre and post. Post-op, you can see there are various ways to see toric alignment. And most importantly, eye trace will be very helpful because it has a toric enhancement software. This is one of the few studies, maybe first study, where you use eye trace to look into quality of vision after toric IOLs, comparing digital versus manual. And we found that the quality of vision is much better with the digital in terms of MTF values and stress ratio value in these cases. Eye trace was used for these study to look into quality of vision. Then misalignment, we know that you can lose the toric power. There can be various ways by which misalignment be there. Classically, it is basically the surgery or a miscalculation of your axis. Accordingly, you can plan to rotate your lens if required. You require to dilate the pupil post-op, see the marks, and check with your axis in these cases. And I do eye trace examination, which will tell you the alignment of these lenses. These are pictures. And if you look into wavefront, we are looking for the perpendicularity of the internal astigmatism and the corneal wavefront. If they are perpendicular, patient is happy. If they are not perpendicular, then patient is not happy. So that is very important if you look at wavefront for these patients. Toric enhancement also will tell you how much rotation is required for a particular case. And with that rotation, how much change will occur in a corneal refractive power, actual refractive power, and what will be the post-op residual astigmatism for this patient. That is a great tool to have to give you analysis here. And same can be checked with the astigmaticfix.com, give you the same results here. Just a few more slides. This is what another case requires a 74-degree rotation, which will give 3 diopter corrections. And you can correct, this was a myopic patient access. Sometimes you have, in IOL master, you have 2 parameters. One is IOL axis, second is refractive axis, reference axis. So if by mistake, if you put a reference axis, your power will be totally different because reference axis is different and the axis of IOL is different in some cases. So that is what has to be checked. This patient had a 25-degree rotation required, but patient vision was quite okay and patient was satisfied. So this indicates not every patient you need to rotate. It depends on the patient's post-op visual acuity and satisfaction. So I'll just summarize. Pre-op, it has a help in doing a wavefront analysis and alpha calculation. Intra-op gives you axis implantation. Post-op is one which is very useful to give you a good analysis of rotation required or no rotation required for your patient immediately or long-term also. Thank you for your kind listening.